I wish you all a very warm welcome, and I thank you for taking the time to join us. I hope you will accompany us on a journey of personal reflection, exploration, examination, curiosity, and are left excited as to where the next journey may take us in our collaborative approach in further developing and enhancing the role of the clinical nurse specialist in palliative care within the acute hospital setting. The World Health Organization designated 2020 as the year of the nurse and midwife. Many celebrations were planned to recognize all that is great about nurses and midwives, who provide highly skilled care with compassion and commitment to patients and their families. While many of those planned celebrations were cancelled due to the pandemic COVID-19, 2020 undoubtedly has demonstrated and reminded us of all that is truly great about nurses and midwives. In 2020, we also celebrate and remember the immense contribution that Florence Nightingale has made to the profession as the founder of modern nursing. 200 years after her birth, the work and concerns of Florence are as relevant today as they were then. When I conjure an image of Florence in my mind, I often see her as holding the lamp and shining its light as she walks among the wounded soldiers in the Crimea, observing them, monitoring them, caring for them, comforting them. Today, we shine the light of this lamp on the role of the clinical nurse specialist in palliative care in the acute hospital. My first clinical nurse specialist role was in a large teaching hospital in northwest London, and I often take myself back to the bedside of the patients and families that I provided care for. I had achieved the academic requirements to be a clinical nurse specialist, but I found myself commencing a whole new journey again in my career. I was certainly a novice, and on reflection, I know that it took me a number of years to become more familiar, more expert in the role of hospital palliative care clinical nurse specialist. To truly understand and embrace the role in its entirety. I was a clinical nurse leader at a different level to when I was a staff nurse, a senior staff nurse on the medical and oncology wards. I had to learn and understand a different way of achieving good patient outcomes other than providing what in my mind I call direct hands-on patient care. From my lived experience, it is a role that I became passionate about and I still am to this day. The role of the clinical nurse specialist in palliative care is critical to improving patient care and outcomes and linking professional practice to evidence-based outcomes. It is also about improving staff development. The job of the clinical nurse specialist is to empower, enable staff, enabling staff to care. My own lived experience, both in England and in Ireland, is that this particular role is often poorly understood, underutilised and under-resourced, and that clinical nurse specialists at times find difficulty in articulating what it is they do. This interest led me down the road of reflection to one of exploration and engagement, and to the convening of a steering group representative of the acute hospitals in the North East, specialist palliative care services, Louth, Meath, Cavan, Monaghan, and the nursing midwifery development of Dublin North East. An initial review of the literature highlighted that there is ambiguity about the role and purpose of the hospital clinical nurse specialist in palliative care, and that it is poorly understood not only by clinical nurse specialists, but other healthcare professionals. The literature also highlighted a variance as to how the role is fulfilled. It was at this stage that the steering group decided to commission research to design, develop and apply an audit tool to measure the effectiveness of the specialist palliative care clinical nurse specialist in the acute hospital. Why is this particular role worth examining? The location of end-of-life care and death has changed significantly in the last century, from people dying at home to dying in institutional settings, such as hospitals or nursing homes or hospices. Acute hospitals have traditionally focused on the diagnosis, treatment and management of serious and chronic illness. However, they are increasingly the place where care is provided at end of life and the location of death. For the purposes of our conversation today, when I refer to end-of-life care, I am using a broader definition. It is not just care in the last days of life, but also includes care provided to people who are likely to die within the next 12 months, such as people with incurable and life-limiting conditions and those who unexpectedly die, including care provided to relatives. Studies in Ireland, including the National Audit of End-of-Life Care in Hospitals and the Survey of Bereaved Relatives, highlight many areas of good practice, whilst indicating improvements that could be made to enhance end-of-life care in acute hospitals. Not everyone will be able to die at home. Not everyone will be able to die in a hospice or a nursing home. So the need to improve the experience of end-of-life care in the acute hospitals for patients and their families must be an important consideration. An increasing number of hospitals have dedicated end-of-life care coordinators who support the rollout of the hospice-friendly hospice programme. And indeed, many acute hospitals have established end-of-life care committees. The focus that they bring to quality end-of-life care in acute hospitals is invaluable. I believe that the addition of designated clinical nurse specialists in palliative care in this setting will further influence the patient and relative experience positively. This study provides an evaluation of the clinical nurse specialist role in Cavan General Hospital. Today, you will hear about the study findings and recommendations. You will hear the perspective from the Nursing and Midwifery Development, Dublin North East, and you will be invited to listen and consider the perspective from practice development within specialist palliative care services. At the end of our time together, I am hoping that we will commit to further developing this invaluable role, which, if resourced and supported, can influence patient and family experience and outcomes at end of life. Thank you. It gives me great pleasure now to introduce Professor Michael Connolly from UCD School of Nursing and Midwifery and Health Systems. Michael is going to present for us this morning the findings and the recommendations of the study.
Good morning, everyone, and thank you, Eileen. My name is Michael Connolly. I'm the Joint Associate Professor of Clinical Nursing at UCD School of Nursing, Midwifery and Health Systems and Our Lady's Hospice and Care Services. I have the pleasure of being the principal investigator for this study, the evaluation of the clinical nurse specialist in palliative care, the role in Cavan General Hospital, along with my team, Dr. Kate Fraser, Dr. Eileen Furlong, Dr. Mary Ryder, Teresa Plaza Escobano, and Professor Philip Larkin. I'm delighted that we've gotten to the point to launch this study report, and I'm here to share with you over the next 20 minutes or so some of the top-line findings from the study. As we know, in Ireland, specialist palliative care is a consultant-led service provided in a range of settings, with clinical nurse specialists providing specialist care, particularly in the hospital setting that we're going to refer to today. Nurses often work independently and are a reference point for clinical advice, care and discharge planning, and family support. In Ireland, 5 core competencies have been identified for the role of the clinical nurse specialist, They are clinical, advocacy, consultation, education, audit, and research. And these competences are important because they form the basis for a number of the questions we asked in the study and in the follow-up focus group and individual interviews. The aim of the study was to evaluate the role of the specialist in palliative care clinical nurse specialist role in an acute hospital setting, namely Cavan General Hospital. It was to identify health professionals and hospital managers' understanding and use of a clinical nurse specialist in palliative care at a point in time 12 months after the role was fully established as a full-time post in the hospital itself. It was to explore experiences of key informants, engagement with, and suggestions for the ongoing development of the specialist palliative care clinical nurse specialist. And it was to identify core aspects of the role arising from the qualitative and quantitative results, while also being informed by key literature. The study was conducted using a mixed methods sequential explanatory approach over 2 phases. Phase 1 started the research with an anonymized survey of key stakeholders, including hospital managers, nurses, nurse managers, and allied healthcare professionals in Cavan General Hospital. And that survey was conducted to identify their knowledge of the value of the clinical nurse specialist role in palliative care. For phase 1, 200 questionnaires were circulated to medical, nursing, and allied healthcare professional staff working across the hospital. And 121 completed questionnaires were returned, representing a response rate of 68.5%. Responses were received from a range of healthcare professionals. Phase 2 was the qualitative data collection phase, and that was aimed at exploring issues gleaned from the results of the quantitative phase of our data collection. And it allowed a period to provide an opportunity for a deeper understanding of the specialist palliative care clinical nurse specialist role and the service, and as well as the service, the impact of the role across the study site being Cavan. We began by asking the survey respondents to identify their role and their current work location in the hospital. And as we can see, the majority of respondents of the 121 were nurses, from staff nurse, clinical nurse managers, clinical nurse specialists, and senior nurse managers, while also receiving responses from physiotherapy colleagues, medical colleagues, allied healthcare professional colleagues who didn't want to identify themselves in a particular role, and other specified roles across the hospital. The location where respondents worked was identified, and there were, as you can see from the slide, there were respondents from very many departments across the hospital, ranging from the acute medical assessment unit to a medical ward. We had some respondents from obs and gynae, also from surgical departments and other departments dotted across the hospital. We asked the respondents to the questionnaire to identify the duration of their clinical experience. And interestingly, the majority of respondents have between 11 and 20 and over 20 years of service. And if there are managers in the audience, it's something worth considering in light of the need to future plan and be mindful of that workforce that is getting older and is likely to retire in the not too distant future. As part of the questionnaire, we asked respondents to indicate whether or not they were aware of a specialist palliative care clinical nurse specialist service provided in the hospital. And delighted to say that over 99% said they were aware of the service. We then asked in the questionnaire for respondents to indicate whether they had referred to the specialist palliative care nurse specialist service over the past time. And of the respondents who answered this question, their main reason for referral was for symptom management or for discharge planning, or a combination of both. Not surprisingly, the majority of referrals for symptom management came from nurses, given that nurses form the largest proportion of healthcare workers across the healthcare system. But there were also referrals indicated from our physician colleagues, our surgeon colleagues, and physiotherapy colleagues, and other health care professionals. Not surprisingly, again, the vast majority of referrals for discharge planning came from our nursing colleagues, but also seeing some responses from physician and surgeon colleagues, as well as physiotherapy and other healthcare professional colleagues. Following on from the referral question, there was a question related to whether or not respondents might have sought advice from the specialist palliative care clinical nurse specialist. And again, the respondents were asked to identify for what reasons they would contact the nurse specialist to seek advice. Not surprisingly, again, symptom management and discharge planning were the main reasons for contacting the CNS to ask advice, or a combination of both of these things, symptom management and discharge planning. Again, unsurprisingly, the vast majority of contacts for advice came from nurses, but also contacts from physicians, surgeons, physiotherapists, occupational therapists, and other health and social care professionals. Again, not surprisingly, the biggest number of contacts for advice on discharge planning came from nurses, while also there was a contact for advice from physician colleagues, surgeon colleagues, physiotherapy colleagues, and other healthcare professionals. We asked the respondents to consider their attitudes to clinical nurse specialist role using a Likert scale, and responding to the statement, strongly agreeing all the way on the Likert scale to strongly disagreeing with the statement. And what we can see is that the vast majority of statements the respondents are in agreement or in strong agreement with. For example, the majority felt that the CNS and palliative care had an important clinical role. The majority felt that the CNS and palliative care plays an intricate role in patient education. Still, a majority felt that the CNS and palliative care plays an integral role in staff training and education. A vast majority, again, the CNS and palliative care is a patient advocate. But when we look at the audit and research role and see whether or not they respondents see it as a core activity of the role of the CNS and palliative care, we see that while there is a majority, that majority has shrunk somewhat, with an increase in those who disagree or strongly disagree, or those who somewhat disagree. So it's an interesting finding to flag to you for what comes later. We asked the respondents to rank in order of importance the core competence of the clinical nurse specialist. So clinical advocacy, consultation, education, audit, and research. Not surprisingly, the vast majority felt that clinical was the most important competence, followed by advocacy and consultation. And quite interestingly, education and audit and research was seen to be ranked the lowest of importance. Now, when we talk about qualitative findings, you will see that when we looked at this question in those interviews, people found it very difficult to actually clearly articulate why they found it difficult to rank, because they felt that all of the competences were important and they were all interlinked. We further dived into this question by ranking the core competences based on the professional role of the person responding. Not surprisingly, our nursing colleagues very much saw the clinical as the most important. And quite interestingly, the advocacy higher for staff versus lower for the more senior nurses. What's interesting is that the clinical is exceptionally high for our surgeon colleagues and our physiotherapy colleagues, but split for our physician colleagues. What's interesting to note is that the lowest percentages for education and audit are found in the nursing group, and the audit and research are quite significantly low percentage terms as an important factor for nurse managers. While interestingly, the other healthcare professionals rank audit and research as that bit more important, say, than consultation and education. Phase 2 findings then, we ran focus groups to a number, and then conducted individual interviews with a number of key stakeholders. For the purposes of reporting the qualitative findings, the participants are identified individually with the number. There was a thematic analysis carried out, and the main themes that emerged were the role of the specialist palliative care clinical nurse specialist, things being done well, and competence. And what you see there is that there are sub-themes under each of the main themes. For the role of the specialist palliative care CNS, we have symptom management, education, staff, patient, and family support. For things being done well, there's a sub-theme of changes that are needed. And for competence, there are sub-themes of most important and least important in the context of competence. So for the role of the specialist palliative care clinical nurse specialist, key quotes that are shown on the slide would indicate that respondents saw that the role of the specialist palliative care clinical nurse specialist is a supportive one. Not so much the hands-on care, but very much involved in patient and family care journey. The link with palliative care services for symptom control, the supporting and encouraging and education seen as important, and the support of the CNS to be collaborative and seen as collaborative, working with all the other specialty disciplines seen as important in the context of the role of the specialist palliative care clinical nurse specialist. Things being done well, the fact that there is now a permanent presence was seen as a really positive thing that's being done well. Beyond that, the person was very honest in saying they struggled to see what else was positive, but was very supportive of the role and the permanence now of the role on site. One of the things that came out was the need to be very clear and define the role very clearly. Massive amount of clinical support being provided by the role, and that has to be articulated very fully and really important. In competence, it was the clinical was coming out a lot, but there was also that nod to research and audit and the importance of it, because without that to support what we're doing, then we may not be able to advance the service or create opportunities for further development of the services. One participant did feel and express in sincerity the difficulty with the delivery of competences, seeing that it may be that the competences are not interlinked, but rather should be delivered. Things should be delivered in each competence individually, rather than seeing them the 5 competences as a conglomerate, as being more together and worked on interconnectedly rather than individually. In our discussion, we point out that the data showed a varied understanding of the role of the specialist palliative care clinical nurse specialist. However, its importance was strongly identified in terms of referrals and support provided from both quantitative and qualitative phases. The qualitative findings identify the importance of the role in terms of symptom management, discharge planning, while also identifying the important role in the context of education and support. Our conclusions are based on the findings from the data, and what we're suggesting is that the specialist palliative care clinical nurse specialist role should be clearly defined within the context of the specialist clinical service provided and in line with the core competencies for the role, that they being clinical, advocacy, consultation, education, audit, and research. The role and responsibilities should be clearly articulated to ensure that the role of the specialist palliative care clinical nurse specialist is understood by all members of the palliative care team and the wider health and social care community within the hospital. The specialist palliative care clinical nurse specialist service needs to be fully embedded in the hospital, including the provision of infrastructure to support the clinical advocacy, consultation, education, audit, and research work of the specialist palliative care clinical nurse specialist. We would recommend that there be key priorities for service, personal, and professional development over the next 12 to 18 months, and these should be discussed within the palliative care team, and where appropriate, identified developments could be led by the specialist palliative care clinical nurse specialist. An information strategy needs to be developed and shared with all hospital staff to explain the role of the specialist palliative care clinical nurse specialist. And I dare say that in these times of COVID, this service has probably been front and center in the provision of particularly end-of-life care and support to those patients who have succumbed to COVID, and also supporting staff. So I do feel that in some ways the role is probably more known now than it may have been when we did the data collection for this study. Also, a strategy for in-service and ongoing education for hospital staff on palliative care should be developed by the specialist palliative care clinical nurse specialist, the hospital palliative care team, and this should be supported by the regional specialist palliative care services for Louth, Meath, Cavan and Monaghan. In conclusion, I'd like to acknowledge my project team, again, Dr. Kate Fraser, Dr. Eileen Furlong, Dr. Mary Ryder, Teresa Plaza Escribano, Professor Philip Larkin, and a special word of thanks to Eileen Crothers, Eileen McGuigan, and the other members of the project steering group who really were supportive of us in the undertaking of this study. I'd like to acknowledge the support of HSE Northeast, particularly for the funding for this research and also in assisting with our ethical application. The research steering group itself very much would appreciate their input and their contribution. And importantly, and most importantly, the staff who completed the questionnaire and agreed to take part in interviews, either at focus group or individual level. Many thanks for joining us for this long-awaited launch of the report, and copies of the report are available and they will be circulated in due course. Thank you.
Thank you very much, Michael, for sharing the findings and recommendations of the study with us. Now, I would like to introduce Ms. Joan Donegan, Interim Director from the NMPD, Dublin North East. And Joan is going to share with us her perspective on the findings and recommendations.
Hello, my name is Joan Donegan, and I am the Interim Director of the Nursing and Midwifery Planning and Development Unit in the North East. And I would like to thank Eileen for inviting me to speak to you today. As my predecessor, Deirdre Mulligan, the then NMPD Director in the North East, commissioned this evaluation together with Eileen, I welcome its publication and look forward to working with Eileen and her team with considering the next steps for implementing the recommendations. Here in the North East, we are lucky to have a regional specialist palliative care nursing service led by Eileen under the medical direction of Dr. Dominic O'Branigan. It is a very highly valued service, and while none of us wish to avail of it anytime soon, we can be assured that when it is required, we have a very competent team to provide the service, so I would like to commend their work. As Irene referred to in her foreword, the clinical nurse midwife specialist role evolved from the 1998 Commission of Nursing, and under the stewardship of the National Council for Nursing and Midwifery, we saw our first cohort of clinical specialist nurses in 2001. 5 core competencies were then identified: clinical focus, both direct and indirect care, patient-client advocacy, education and training, audit and research, and consultant. This evaluation has gone some way in providing us with some evidence that the competencies of audit and research, education and training are the least understood and evident. As clinicians, it is only right that the main focus of their work would be on clinical care and working directly with patients. But those of us in leadership roles will need to plan on how we can enable them with opportunities to develop those other competencies. This evaluation was conducted in an acute hospital setting, and we have evidence to show that the introduction of a new service into this complex environment can be challenging and not underestimated. The HSC in 2018 published Understanding Change in Complex Health Systems, which was based on a literature review on change management in health and social care in Ireland from 2007 to 2017. They found that people in power, culture and social interaction, and leadership and learning as the critical elements required to bring about change. Specialist palliative care teams are often small, as in this setting, so this demands a greater onus on us in nursing leadership roles to provide support to our clinical nurse specialists in these settings in meeting these challenges. Dr. Geraldine Shaw, the current Director of Nursing and Midwifery Services Director, or the ONMSD for short, together with the 8 Nursing and Midwifery Planning and Development Units, have continued to support the development of the clinical specialist roles since the dissolvement of the National Council. Here we have advocated for the role of the clinical specialist, and Cameron Buckley, the Area NMPD Director in the South, is our national lead for specialist practice, and is currently collaborating with both the Department of Health and the Nursing and Midwifery Board of Ireland on matters related to specialist practice. Much of this work has evolved from the Department of Health policy on the development of graduate to advanced practice, where there is recognition of the importance of the clinical specialist role in meeting specialist population and local healthcare. The role of clinical specialists offer nurses and midwives a career pathway, incorporating professional development within interprofessional team structures. The current minimum educational requirements to be met are set at postgraduate diploma level in the specialist area, and this is now in all job specs since 2010. While nurse and midwife medicinal product prescribing and referral for medical ionizing radiation are not strictly essential, but desirable if relevant to the role, and should be considered at this level of nursing and midwifery. Our Chief Nursing Officer, Rachel Kenna, at every forum, recommends that nurses and midwives work to the top of their licence, and my own view is that to provide a holistic service to patients, these further registrations for the clinical nurse specialist are essential. The Office of Nursing and Midwifery Services are currently the interim holder of the database and of clinical specialists, and it is proposed that this database will be then migrated to the Nursing and Midwifery Board Nightingale IT system. To facilitate this, there is currently work going on classification of titles of clinical specialist roles, as currently there are multiple classifications and sub-classifications of titles. For instance, within palliative care, there are 5 subspecialities, so in preparation for credentialing systems, these may be merged into one palliative care specialist classification. This credentialing system is under consideration by the Nursing and Midwifery Board for annotation against the nurse and midwives registration. Regionally, as I said earlier, there are 8 NMPDs around the country who each have a designated NMPD officer assigned to the clinical specialist development. They provide one-to-one support to directors of nursing and midwifery on areas of potential development into specialist roles. They provide advice on recruitment and job specs, and then collate all the necessary documentation prior to sign-off and verification by the NMPD and area NMPD directors before being entered onto the database. So you can see it goes through an extensive and robust quality assurance process. Much time is currently being devoted to tracking existing clinical specialists who are not on any database. So you can see from what I explained earlier, to ensure that credentialing occurs for each clinical specialist, we need to have this information. To support clinical specialists when they are in the roles, here in the North East, the designated officer, my colleague Rose Lorenz, has provided a number of leadership programs to support them in their roles until at the moment we have almost reached saturation. Participants of the program evaluated them very well, and there were some excellent poster presentations of innovative projects that they lead on with the focus of improving the quality of care. Rose has also formed a regional forum for clinical specialists, an annual meeting where an agreed speaker comes and addresses them. Regretfully, COVID has stopped that from happening in 2020, but we hope to reconvene in 2021, because I think we all agree the need was probably never greater. We also in the North East have a peer clinical supervision group which is chaired by Eileen and led by the now director of the CNME, Mairead McGahan, who in a former life was a palliative care nurse manager. Together with Eileen and Mairead, we will start making plans on targeting clinical nurse and midwife specialists as peer groups, and in particular looking at specialist palliative care clinical nurse specialists. Under the guideship of my colleague Roisin McLaughlin, the CNMEs nationally are forming a consortium of centres, both of HSC and voluntaries, to achieve QQI approval to deliver level 5 to level 8 programmes for nurses and midwives and healthcare assistants. It is anticipated that this will be achieved mid-2022, and I am sure that Mairead and her colleagues in all of the CNMEs will be providing clinical nurse and midwife specialists opportunities to develop their education competencies by contributing to these programmes. The findings of this report today, with recognition of its limitations, demonstrates that we need to do more than providing professional support to clinical specialists, and in particular a small team in a complex healthcare environment. At organisational level, we need to consider how we can improve on the integration of the role into a wider healthcare team and informing all elements of organisational structures, both in hospital and community, of the value that this role can bring to the delivery of a quality, person-centred service. I look forward to working with Eileen in planning and reviewing the recommendations in this document. Thank you.
Thank you very much, Joan. We are delighted that you were able to join us this morning. I now wish to introduce our last speaker this morning, and that is Eileen McGuigan. Eileen is Practice Development Coordinator for Regional Specialist Palliative Care Services, Louth, Meath, Cavan Monaghan. And Eileen is going to share with us her perspective in relation to the findings and recommendations of the study.
Thank you, Eileen, for your introduction, and thank you all for joining our event today. We are almost at the end of our launch, and I will not keep you long. It is lovely to be here today. I acted as the gatekeeper for this research, and I would like to acknowledge the wonderful warm welcome I received from everybody I met during my time in Cavan General Hospital. My presentation is titled Permission to Dream, and I will revisit my title choice at the end of this presentation. I would like to begin by sharing a quote that really resonates with me and which I keep pinned to my computer where I can see it every day. The quote is from a book that is titled Cutting for Stone by Abraham Verges. This book is a sweeping story of Africa and America, doctors and patients, exile and home. Twin brothers born of a secret union between a British surgeon and a beautiful Indian nun, who are orphaned when their mother dies in childbirth and their father abandons them. It is an unforgettable journey into one man's life and an epic story about power, intimacy, and the curious beauty of the work of healing others. The quote, "The unexamined practice is not worth practicing." I believe all of us today would agree with this statement. However, evidence suggests that consistently research findings fail to be translated in a timely measure into practice. Michael and his team of researchers have found the story in the data, and he has shared it with us today. Thank you, Michael. But it is now up to us to take this story, examine it, create a new story, and practice the examined. This requires change, courage, support, and the curiosity to see the role differently for clinical nurse specialists in palliative care, for our nursing profession, for our patients and their families, and for our healthcare colleagues who support the delivery of palliative care in Cavan General Hospital. The story of the data we heard and listened to today demonstrates the value of the clinical nurse specialist in palliative care role and reflects the thoughts and perspectives of the whole multidisciplinary team of healthcare professionals within Cavan General Hospital. It offers a glimpse of what can be. Let's imagine the CNS in palliative care role, where all 5 core concepts are realized daily. What heights could be achieved for our patients, our clinical nurse specialists, our profession, and our colleagues? We cannot continue to achieve only part of the CNS role when we have opportunity to achieve so much more, to thrive and make the role flourish. This evaluation offers us the opportunity to build excitement, to dream big, and to reach higher for clinical nurse specialist roles in Ireland. To achieve this, I believe that practice development offers us an approach to enable us work together to achieve the true potential of this role. Practice development is a systematic approach which aims to help practitioners and healthcare teams look critically at their practice and identify how it can be improved. It focuses on people and practice to strive together to achieve the best outcomes for their patients. And I believe it is a good fit to help us realize the potential of the CNS role in palliative care. Practice development is well established within Cavan General Hospital. The evaluation incorporates a multi-professional perspective of the role, and together we can support and enable the role to develop. It can be difficult to know where to start. I believe that today we have been given the starting point, a broad understanding of the current role from the perspective of all disciplines in Cavan General Hospital, and some recommendations to help us rethink how the role may develop. We know the role is highly valued, but clinical nurse specialists need space, support, time, skills to develop further all core concepts of the role, and to continuously practice cycles of observation, reflection, and change. I do not have all the answers, but what I can share with you are a few things that I have learned that need to be present for practice development to have an impact. Firstly, we must trust the process. It works. Managers must be involved in practice development. The needs of the patient and patient outcomes are fundamental to practice development work. It requires a shared vision of what can be. It requires good communication and working relationships. Practice development coordinator role is one of facilitation. It is not one of doing. Effective practice development requires 3 principles: collaboration, inclusiveness, and participation. It is a journey that has many twists and turns, but one worth staying on, because when the storm has weathered, the view is truly spectacular. It requires authentic being, respecting all voices, enabling. It is an active process and requires those at the front of clinical practice to be drivers, the dreamers, because this is where we can change our practice and make things the best that it can be for our patients and their families. So what do I believe practice development can offer to enable the clinical nurse specialist in palliative care to flourish? It can bring its focus of working with you to critically explore the role and practice of the clinical nurse specialist in palliative care in the acute setting and bring about change that makes sense to those who are using it. I'd like to return to my title, Permission to Dream. Why did I choose this title? I chose it for its simplistic impact. Sinead Burke chose this title as a chapter title in her book, Break the Mold: How to Take Your Place in the World. The opening line of her chapter states, "The act of making a dream a reality does not happen overnight. It takes time, effort, and perseverance, but you can make it happen." I hope this quote from Sinead's book inspires you, like it has inspired me, to leave you with the following thoughts. It is up to you. It is all about you. Let practice development make your dream a reality. Let's make a difference together. Let's make nursing great. Let's break the mold. Let's practice the examined. Thank you.
Thank you very much, Eileen, for an extremely thought-provoking perspective on how we can move forward together in further developing this role, embracing a practice development approach. We have now come to the end of our time together. And before I close, there are a number of thank yous I wish to convey. I wish to express my sincere thanks to the members of the steering group who gave so generously of their time and expertise to this work. To the Nursing and Midwifery Planning and Development, Dublin North East, thank you for funding the study. To Professor Michael Connolly and his team, thank you for your research expertise and commitment. To the Director of Nursing in Cavan General Hospital for your support in enabling the research to have been conducted in your hospital. And to the staff of Cavan General Hospital, a sincere thanks for your genuine participation. To my colleagues in Regional Specialist Palliative Care Services, thank you for your support and contributions, in particular the Cavan Monaghan team. Thank you to Precise Events for hosting our virtual launch in such a professional and enabling manner. To Monique McGivern for ensuring smooth communication and planning detail, thank you for your commitment and hard work. We have now heard the recommendations, and it is up to us to adopt an integrated approach to ensure the adequate resourcing and ongoing development of the role and practice of the clinical nurse specialist in palliative care within the acute setting. As we draw to the end of 2020 and to the year of the nurse and midwife, I truly believe we have a lot to celebrate and look forward to in 2021. We do need to shine a light on this role, but we need to take a step further and under this light have the courage and confidence to measure and examine what it is we do as nurses. For the role of the clinical nurse specialist to be truly effective, all 5 core concepts need to be part of everyday practice. This undoubtedly will be a change, and sometimes we know that change can be the enemy of progress. Indeed, change can ignite feelings of fear as it challenges us to move out of our comfort zone. However, if we remind ourselves of the founder of modern nursing, Florence Nightingale, and think of her words, how very little can be done under the spirit of fear. I wish to thank you all for joining us this morning, and I would like to take this opportunity to wish you and your families a very happy and peaceful Christmas. Thank you.